Top Med Talk. So welcome to Top Med Talk, live from the Union League, Philadelphia, USA. We're here at the 3rd Annual Transatlantic Quality Improvement Leadership Forum, focusing on perioperative medicine and enhanced surgical recovery. I'm Monty Mython, Editor-in-Chief of Top Med Talk, the broadcasting arm of evidence-based perioperative medicine, that's EBPOM, and I'm joined today by special guests, Dr. Carol Peden from USC, so University of Southern California, Dr. Andrea Kurz from the Cleveland Clinic, and Dr. Lee Fleisher from UPenn, who's co-chair of this meeting, and also relatively recently appointed as the editor-in-chief of the journal Perioperative Medicine. Now, this forum is a gathering of leaders in perioperative medicine and enhanced recovery to share ideas and hopefully drive dissemination of best practices. So I'm going to ask everybody for some reflections on yesterday, but I'm going to start by Lee just telling us a little bit about where we're sitting at the moment, the Union League, and maybe even a little bit about this magnificent room.
So the Union League was built in the 1800s, around the time of the Civil War, to support the Union in our Civil War. It was a very conservative establishment that has the statue of Abraham Lincoln, this being the Lincoln Room. It actually contains pictures of every single president from the Republican Party since Lincoln's time, as well as some phenomenal portraits of George Washington. Interestingly, it was incredibly conservative and was basically a male bastion. And we have two women who have joined me today, and just probably 50 years ago would not have been allowed to be members of this club, but the club is now much more open, but still does not have any Democrats on the wall.
So when President Trump finishes his term, which is inevitable for any president, his portrait will join the others downstairs.
Including President Nixon's on the wall.
Nixon. Right, glossing, moving on quickly. The reflections on yesterday, Lee.
Yeah, so yesterday it was really interesting in that we've moved past over the last 5 years from a discussion of what is enhanced recovery, what are the key elements, to really how do we disseminate it into clinical practice. So I found yesterday's talks really about overcoming the obstacles, both for our surgical and anesthetic colleagues. Today maybe more discussions around how to get the leadership buy-in. But that's really been the major focus and change that has occurred over the course of this multi-year leadership forum.
So the debate's moved on from does enhanced recovery help to how do we make it happen everywhere as quickly and effectively and efficiently as possible.
Well said.
Thank you. And broader than that, this whole sort of perioperative medicine thing's creeping in. The discussions yesterday were starting to bubble up about treating anemia, diabetes, fitness modification.
And blood pressure.
So straight, Andrea, some reflections on yesterday.
I actually completely agree with Lee. I think the problem we have now is to efficiently implement things, probably use IT and any other means we can use in that matter. And I'm a big fan of decision supports and sending alarms to people, which is really only part of that entire problem, because unless people want to do it, so anesthesiologists or surgeons or whoever it might be, and they buy into it, we can have any decision support we want, and it probably won't work. And the technology part almost seems the easy part. So the discussions we had on dissemination and how to actually get to the anesthesiologist, the leadership, etc., is probably one to concentrate on.
So a recurring theme yesterday was, despite people predominantly having large, well-established electronic health records, was failure to comply with elements of these pathways. So people lay out a plan which, let's for argument's sake say it's got 15 things in it. Mm-hmm. Maybe only 8 of them get done reproducibly and reliably. Now, surely it's not like that at the Cleveland Clinic. You're a beacon of big data, decision support, artificial intelligence. It has to be greater than 90%.
No, it's not. And I think that's what I meant before. the data, the analytics, the whatever we have there isn't the difficult part. I mean, people can turn off decision support. People can turn off alarms. They can ignore them. And I think the third part that comes into that then is actually the quality metrics and how to reinforce them to basically close the loop.
Okay.
So to give people a tool and then somehow make them use it and then check how well it's being used. And I think that last part we are still a little bit short of.
So we're still in this situation, it would seem, and there's often, with giving anaesthesia, there's often comparisons with flying aeroplanes.
Mm-hmm.
It seems as though we're still in a position where very many of us still don't trust the autopilot, and we think we're better at flying the plane, and we want to fly it our own way, which is often a different way.
Right.
Through the storm or through the clouds. Now, in the airline industry, we're pretty certain now that is what results in worse outcomes. When are we going to get tougher?
I think we will really have to make major changes soon.
Okay.
Because in the entire field of perioperative medicine, I mean, we talk a lot about it, and the ASA talks a lot about it. I don't know whether it means much yet. We can only make changes if we make them as tough and soon as possible.
So, Lee, do you want to come back on that? And then Carolyn?
Well, I think what's interesting, and particularly about the hypotension work and blood pressure control that Andrea has worked on, whether we believe in the absolute values or just the trends, we're now learning that the traditional approach that if we do a good job, patients will do fine, and that if we do a great job, patients will do fine, but the difference between a good and great doesn't make a difference. Well, I think really the last 5 years or even 10 years with some of your own work is starting to say that even intraoperative management will make a difference to outcome, as well as preoperative management and post-op. And that's really been the shift that I think we have to rethink getting the patient through the perioperative period with accepting this high complication rate, but we don't kill them, is not adequate.
So isn't that, Lee, shame on us that we've thought that what we do during the procedure is so unimportant that doing it kind of okay is good enough? I've always believed that doing it with incredible attention to detail and as perfectly as possible makes a difference to that patient's life.
Well, but that gets back to the fact that we said we're so great that the Institute of Medicine said we're the only field that believes in Six Sigma. That's like not killing somebody by something we do, as opposed to doing great work.
Carol?
I think going back to the comments on standardization, I think one of the things that enhanced recovery offers is some key components along the pathway that can help to move us into some sort of standardization, things that you have to deliver on. And there's increasing evidence that if you can standardize and change your care around the patient as opposed to around every individual clinician that comes into contact with the patient, outcomes improve. A good example we were discussing yesterday, the health system Geisinger. They offer a money-back guarantee, and one of the ways they've increased their performance is to standardize everybody. And you can take an average team and make them a very good team by everybody working together and knowing what the pathways are. And I think enhanced recovery offers elements to get there.
So if in Geisinger somebody doesn't comply with the elements of the pathway, so they do 3/4 of the job, if you see what I mean, you can argue about whether that's true or not, but if they complied with 3/4 of the requests, how much money does a person get back?
Yeah, the financial performance is linked to meeting.
Do they get all their money back, or do they get 25%?
So that's a little different.
The patient, but the clinicians have some financial metrics to meeting the quality.
So I've heard about that in other systems.
Yeah.
So in other words, when we sit down at the end of the day and we divvy up the bonuses, if I've been highly compliant, I get a bigger bonus.
Yeah.
Lee, that's bribery, which usually works better than...
No, it's incentives.
Sorry.
But the Geisinger is two different things. One is the incentive for the physicians to comply with performance metrics. The patients get back if they're unsatisfied with care, which is a little different, but it's actually saying that patient satisfaction with their care matters.
Yeah.
And Geisinger is willing to give back part of their copays.
Excellent. So this year on Top Med Talk, we made a decision that we're going to focus on thrthey big areas. We're going to discuss everything, but the three big areas relate to blood pressure, i.e. blood pressure, hemodynamic stability awareness. That they relate to the opioid crisis, as it's referred to, and brain health. Those are our three big areas, and we think they overlap, and they're all sort of baked into different parts of enhanced recovery. So just very briefly touching on the opioid crisis, for example. Lee, what did you hear yesterday?
Well, what I heard yesterday and what we're doing in our own system is we're partially at fault in that we've given our patients too many opiates to take home. They continue them for 6 months or a year if we give them enough, and that what many health systems are doing is certainly restricting post-discharge opiates. And then what I heard from numerous individuals is whether or not there's an advantage to reduce opiates perioperatively, in the hospital.
So we heard about some people trying to do opioid-free anesthesia stroke analgesia. We heard about some people trying to send patients home with no opioids. And we heard that some people are down now to 3 days to that. But other people are still way out there. Carol?
Yeah, I think, again, any moves we can to be sensible about our opioid use. Obviously, we want our patients to be comfortable, but the comment we were discussing last night is if you're still taking opioids several weeks after your operation, surely the clinicians want to know, because why is that patient still in pain? If it's a joint replacement, something's clearly not right. So we should be picking up on that and seeing them. So we shouldn't be giving these long periods of uncontrolled opioid medication.
So the second week of prescription, for example, may be a very good reason
be a trigger
to trigger the patient. Andrea?
We are actually trying to do opioid-free anesthesia, and I thought a lot about that last night. I actually am not so sure anymore that that's the part that really matters. And whether we aren't going overboard there and get unintended consequences. I would agree with Lee. Anything after surgery should be restricted in a reasonable fashion, but to go completely without opioids might actually, in the long run, intraoperatively, prove wrong.
I agree with that. we tried to go in the UK opioid light in the operative
that
period,
makes sense,
and then focus on leaving the patient needing as few as possible going home. The reason is people dive in with alternatives that are relatively under-evaluated. We don't know their full safety profile. They've never used it before, but they're going to use it today on Mrs. Miggins, who's high risk. So I think don't rush at that one. Is that a fair comment?
Absolutely.
Opioid lights to start with.
So. Absolutely.
I've seen protocols where they use local anesthetics and they say keep intralipid in the room.
Yeah.
I'm not sure that makes sense.
So proceed with caution. So can I jump to the hemodynamic management then? Andrea, in particular, the Cleveland Clinic's led the world in awareness about blood pressure, hemodynamic instability. I think this year everyone's going to be very focused on more attention to detail. What's the plan at the Cleveland Clinic?
Intraoperative blood pressure control should be a given, at least in those phases where we as anesthesiologists are responsible for it. I think there's no question about it. But I do believe that the big thing should be continuous blood pressure monitoring the first few days on the ward.
Okay.
Only because the complications happen there. And we've now have a few associations that these come from randomized trials that post-op management or hypotension is associated with bad outcome.
So do you think POISE 1, that was one of the big problems with stroke?
Yeah,
is the undiagnosed hypotension?
Yeah.
So that's really important.
So when we have a broader population listening to us discussing these issues, and particularly patients and the public, they're kind of a bit shocked that we're not measuring blood pressure more often post-operatively, yet we seem to be accepting the fact that hypotension is common, often profound, often very dangerous. And the technology's there, but our reluctance to universally adopt the technology is this old lack of evidence thing. So should we adopt, then prove or disprove, or should we wait? I'm going to ask Lee to answer that one, because you're often wary about diving in before we have the evidence. It's a big financial lift on the capital front.
That's some of the problems that what we're seeing, particularly in the States, is if you have limited resources what is the most useful.
I don't want to hear the limited resources thing from the USA. Okay.
And especially from
You
Pat.
can give me any excuse you want, but I'm not accepting that one.
But I think when people are trying to make these decisions, what's the best technology? I mean, my question would be not, is it blood pressure? Is there some monitor of perfusion? And is Apple going to put watches on everyone, given that it's an anesthesiologist who was the CMO at Apple, I mean, who was a sensor guy?
But Apple Watches ain't cheap unless I've missed something.
I think we're going to be creating something.
Okay.
I think in 3 to 5 years, you're entirely correct.
But we wait or we act now? Because
there isn't so much. There is actually not that much technology available.
Right.
Okay.
If it were, I think many of us would have jumped in.
Yeah.
But it's not, and that's the shocking part. But that might go back to the fact that there didn't seem to be enough evidence. So I don't know what's the egg and the chicken here.
But let's not forget simple early warning scoring systems that if you do them and you respond appropriately, often patient deterioration is predictable over a period of time, and so we have to get in early and respond to it. So that it's helpful if you have the technology that sends out the alerts to the appropriate people, but you can do it just by the nurse adding up the score and calling somebody.
So I think that'll be a big change this year. So the crowd is gathering behind us for the leadership forum. So Carol, I just want a quick takeaway. You did a fantastic interview last week with Desiree Chappell on the round table at the ASA meeting. If you were to give me 5 or 6 things, okay, that I, as a new enthusiast in this field, could go back next week and start to act on, what should I do?
Number 1, raise awareness in your department about the brain health issues, and the ASA perioperative brain health initiative website has a lot of resources. So number 1, raise awareness. Number 2, think about it in every patient over 65 years of age undergoing inpatient surgery. Number 3, do simple tests for those patients which don't diagnose anything. They tell you that the patient may be at risk. Talk to the patient and family. Get them to bring in things to orientate themselves, photographs, glasses, hearing aids, and avoid drugs that can trigger postoperative cognitive dysfunction.
We're almost out of time. Lee, this brain initiative, remind us again.
The ASA Perioperative Brain Health Initiative. It's really a multi-stakeholder initiative that we're hoping to. We're working with the American College of Surgeons. We're working with American Geriatric, AARP. That's really a public and provider-facing initiative to, just as Carol said, create awareness so that people do the right thing, which is a little bit of what we're talking with blood pressure too. If there's awareness.
And the ASA is the American Society of Anesthesiologists. The AARP won't necessarily be known to people around the world.
So that is a group. It used to be called the American Association of Retired People. So essentially, it's a public advocacy group for the elderly. In fact, at age 50, or when your spouse turns 50, so it was before age 50 for me, start sending you bulletins, and they really are a great educational service that would help make patients aware.
And we sat down with their president recently, who gave us my favourite line of the year, which was ask the patient what matters, not what is the matter, which is a fantastic line. I believe they've got 28 million members. Now that's a membership, so we should be able to drive a message through that group. Well, thank you very much indeed for sitting down with us. We'll see if we can have a chat later. We now need to get on with our leadership forum. So everyone, don't forget to listen to topmedtalk.com, and in particular download our podcast.
Thank you.
Thank you.
Thank you.